How appropriate. We have done we have had tremendous progress in trying to classify a lot of questions related to seizures and epilepsy, the seizure types, the type of epilepsies, and now the syndromes. And I would like to tout a former Canadian, Elaine Wirel, who was in charge of the task force to define the syndromes. And I will cover some of them later on. Now, a piece of advice: these papers are magnificent, that they were published a year ago in Epilepsia, but I don't think it's possible to read them. Only if you have a case that you think to see if it fits the syndrome is the time to see them. Otherwise, it's very difficult to remember because there are a lot of amazing points and details that you should be aware. So you heard what my titles are, and there's the usual disclaimers. I have received grants from a lot of funding agencies and also from private foundations. And I would like also to thank the many patients who teach us. I put this disclosure there all the time, although I'm not sure I will mention any drugs, but in case I do, may or may not have been approved for use in patients. And I do have a patent on a model of infantile spasms, which I think is the best model to figure out how we can develop new treatments. And the person who is running away with it is Dr. Aristea Galanopoulou. About 3 weeks ago, we lost Dr. Wada. And I would like to dedicate this lecture to Dr. Wada. I see that you have the leaf as part of the Canadian League Against Epilepsy. This is a hand painting that Dr. Wada sent to me many years ago with a message for all of us, that the future is all yours for the creation of new knowledge and the exploration of the brain. And June Wada was an amazing leader, mentor, supporter to all of us. And we cherished all the things that he gave us over the years. The learning objectives in this lecture is to discuss the definition of a seizure, the classification of the seizures, the classification of neonatal seizures, and I will point out that this may be applicable to any age group where the patient is unresponsive, unable to tell us what they feel, the classification of epilepsies, and the proposed syndrome, including some terms that are very essential, such as genetic, self-limited, and developmental and epileptic encephalopathies. So the definition of the syndrome was proposed in 2005 by Fisher. And the problem with this definition, the definition is that an epileptic seizure is a transient occurrence of signs and symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. This is an operational definition that it seems to be okay. However, it does not reflect what necessarily a seizure is, because it may not necessarily be excessive, and the same kind of discharges that we describe here can be seen in other conditions in neurology, for example, movement disorders that can become paroxysmal. So we need a better definition, but for the time being, it helps us move along. The classification of seizures is also was created by a committee that Bob Fisher was in charge. And I think now this has been accepted for most people. What is important for this classification is that we try to define whether the seizures have a focal onset. And if there is no focal onset, it may be a generalized onset or an unknown onset. Let's quickly dispense with the unknown onset. If you do not know how the seizure begins, then the seizure should be described as unknown onset. Unclassified seizures means events are those that we're not sure if they're seizures or not. The importance to try to identify the focality is because that will lead us in the treatments that go beyond anti-seizure medications, namely surgeries and related, mostly surgeries, but also procedures that may evolve in the future with electrical stimulation of the focus whenever this comes to be. Under focal onset, if the person loses consciousness at any point during the event, this is called a focal onset with impaired awareness. And then we classify the symptoms that we see. And most of them are motor onsets that we can see and we can videotape as well, or the family can videotape. But non-motor onsets are totally dependent, except for behavioral arrest. The cognitive and emotional and sensory are dependent on the person to be able to describe what they feel, which may make it difficult for the younger age group, and especially those that are very young or very old, that they have lost means of communications, including being under in a semi-comatose state. A lot of the seizures of focal onset will become focal to bilateral tonic-clonic. And again, it's important that we teach all our doctors not to call every seizure generalized tonic-clonic seizure. If we miss the focal onset, we lose one of opportunity to treat the patient when ASDs fail. Generalized onset is that we see motor manifestations from the beginning, and you see the list here. And non-motor is usually the absence type of seizures, and we have the different categories: typical, atypical myoclonic, or ILAE myoclonia. What I would like you to pay attention is to the categories that they have the number 1 next to it. And these are seizures that they can be either motor, focal or generalized from the onset. And this is important because it used to be thought, for example, that all epileptic spasms are bilateral or they have generalized onset. But this is not true. Some of them will start focally, and that will allow us to create appropriate treatments. There are rules for classifying the seizures, and they are optional. The idea is that we add as much as we can for the information that we epileptologists will do. However, in the emergency rooms, that is not going to happen. And if you have the first opportunity to take the history for the electronic medical records, it's very important that you describe the best that you can if the seizures are focal or non-focal. And we have also some other terms that's of interest, which will also affect the classification of the syndromes. And absence is atypical if it has a slow onset, marked changes in tone, or EEG spike in waves that are less than 3 per second, or sometimes more than 3 per second. The term clonic and myoclonic, I'll show you the next slide to see how we can try to separate it. It's not always easy to separate it clinically. Sometimes it is. And ILAE myoclonia refers to a forced upward jerking of the eyelids during an absence seizure. Now, the figure here shows you 3 different kinds of seizures. A is a myoclonic jerk, and you can see how brief it is. A tonic seizure, and this is being recorded by having an EMG in the deltoid, which is a lot of the work that's being done in France. And you can see that the tonic seizure has the continuous tonic contraction of the muscle. And you can see also what an infantile spasm will be different from the myoclonic seizure. And Fusco and Vigevano have proposed that this is associated with a rhomboid pattern that helps us identify what the event is if you don't have the video. Supportive information that we need to ask is videos brought by the family. And if we follow the patient, ask them to take videos anytime they see the seizure after they calm down. the EEG patterns, the lesions, by neuroimaging, the laboratory results. We will discuss the likely pathogenic variants, and the goal is to try as best as we can to diagnose an epilepsy syndrome. But as I mentioned, this is a good classification for a person who can talk. In the neonatal ICU, we have a problem because the patients cannot talk and tell us what they are. They're usually in altered mental state. And the babies have a lot of movements that we do not know if they're seizures or not. So a task force led by Ronit Pressler developed this algorithm where if we see a suspicious movement, we ask for a video EEG, and if this is not available, an amplitude integrated EEG, and then we figure out if there is a seizure, which may be associated with clinical signs or without clinical signs. And the seizure types are important, and they're described below. They can be automatisms, clonic epileptic spasms, myoclonic, tonic, and sequential seizures. These are the ones associated with motor manifestations. There be also seizures without any motor manifestations and seizures that they cannot be identified. The difference here is it's not the first symptom that tells us that there is a focality, but it is the predominant symptom that the baby will have. And in sequential seizures, they go from a different variety of motor manifestations and non-motor manifestations because they can have a behavior arrest, and they can be seen in many genetic diseases. So an important take-home message is the classification for the neonates describes what is the predominant symptom or signs. In the classification for the seizures in awake patients is what is the focal, the first manifestation. In the patients that have seizures only during sleep and nobody has seen the beginning, they become as of unclear clear localization. There is a very recent paper published by Elisa Yosevitz in the New England Journal of Medicine, and it's a wonderful review of seizures in the neonate, making the point that the majority of the seizures in the neonate are associated with acute provoking events, and about 62% of those are associated either with hypoxic ischemic encephalopathy or infarction or hemorrhage. I would like to point out that this may be also very helpful to be used in the elderly when they come in with changes in mental status, and we're asking to see if they have a seizure or not. And then you have genetic or metabolic abnormalities and brain malformations that may lead to the development of epilepsy. Most of the cases of the acute provoked seizures do not lead to the development of epilepsy, and the current recommendation is that the patient should not be treated after the first time they're in the ICU. They should be off medications by the time they go home. From the seizure semiology, one can say what kind of etiology you can think. And I would like to point out easily to see that is that if you have patients who have seizures that they are clonic, the possibility that this may be a vascular event is highly, highly on the list. And if you have seizures that are either myoclonic or sequential, you should think about metabolic/genetic diseases. And this is a table that tells you how the seizures in the neonate can occur as a function of age, and you can see that in Elisa's paper too. So I already mentioned that some of the seizures that we classify is acute seizures, but we do not know what leads to the development of epilepsy, and there is a lot of studies that they are taking place to try to identify biomarkers that they will tell us after you have one seizure whether you're going to develop epilepsy or not. And we know that there is a certain percentage of patients that they may not develop epilepsy. Another ILAE task force developed a definition of what is epilepsy. And here, one has to be careful, and I can criticize it because I was a member of the task force. The definition is at least 2 unprovoked seizures occurring more than 24 hours apart. And the reason for the 24 hours apart is to rule out the possibility of an infection. However, an infection may last more than 24 hours. It's an okay way of approaching it. The other possibility, the other thing that is not considering with this definition is what you do with febrile seizures, because we tend to think that if you have complex febrile seizures, you may have a higher chance of developing epilepsy, which is probably not true, especially if the seizures are recurrent within the same day. And you can ask me about that later. You can also make the diagnosis of epilepsy if the person has an unprovoked or reflex seizure and a probability of having another seizure that's at least 60%, which is similar to the general population, within 10 years. This is a very messy sentence, and the way I interpret that is that if your stomach tells you that this patient may have epilepsy, then consider it as being epilepsy. We don't know what 60% is. We had to put some numbers there. And then we have to have a diagnosis of an epilepsy syndrome. And when this classification was proposed, indeed, we did not have a unified classification of the epilepsy syndromes that as a community we accepted, but with the WIREL task force and TNUPER task force, now we have at least a guideline. Regarding the seizure, the classification of the epilepsies, there is this report from Schaeffer. Again, very, very important. We start with the type of seizures. They can be focal, generalized, or unknown. And then we go to the epilepsy types, which may be only focal, only generalized, or combined generalized and focal. And of course, if you don't know the seizure type, it's unknown. And from there, we would like to deal with the epileptic syndromes. The major contribution of this is the 2 columns on either side. One is that we need to address the comorbidities, and the other, which is a recurrent theme every time I talk about epilepsy, is we need to know the etiology. And at this point, we have genetic, structural, metabolic, immune, which is relatively new. It started about 15, 20 years ago, infectious, and unknown, and hopefully we will have more categories as we move forward. And this is a slide to remind you that always think of the possible etiologies. In the neonate, we're dealing with acute provoked seizures, so the possibility of having hypoxic ischemic is very high, as well as vascular events. And as I mentioned, that also can be applicable to older patients. There are certain terms that we tend to use now with the involvement of genetics, and the preferred term is likely pathogenic variant. And it's important to emphasize that the likely pathogenic variant may have various clinical phenotypes, like SCN1A, and a clinical phenotype may be due to various likely pathogenic variants, like the infantile epileptic spasm syndrome. This is going to be a quiz afterwards. If you can remember all these genes, that's about 10 years ago. There are more to figure out. And also, please remember that multiple etiologies are possible. So tuberous sclerosis is both genetic and structural. GLUT1 deficiency is metabolic and genetic. And fires or voltage-gated potassium channels can be both structural and immune. The next step is what was published last year, which is a syndrome definition. And there were a lot of discussions on how to describe the syndromes. I will not go into that, but I like what we came up with. Is a characteristic cluster of clinical and EEG features, often supported by specific etiological findings. It is, if you make the diagnosis of the syndrome, then this carries prognostic and treatment implications. And syndromes often have age-dependent presentations and a range of specific comorbidities. The syndromes that we ended up including do not include certain anatomical syndromes. So, for example, frontal lobe epilepsies because we do not have all there are multiple etiologies that they can do that, and future classifications will help address those. Elaine Werrell proposed as a core feature is that there is the characteristic electroclinical feature, and then you would like to have as much as specific prognosis, comorbidities or lack of those, and unique etiology. But sometimes there are some syndromes that they have variable prognosis, various comorbidities, and various etiologies. Within this classification of the syndromes, and that already started from the classification of the epilepsies, we did away from the term benign, because although seizures stop, the many epilepsies are not benign. And this it may include childhood absence epilepsy, or what we used to call benign epilepsy with centrotemporal spikes, where the learning concerns. And now we replace that term with self-limited epilepsies, and there are many in these categories. In 2009 and 2010, Annie Berg led another task force that introduced the concept of epileptic encephalopathy, meaning that the epileptic activity by itself contributes to severe cognitive and behavioral impairments above those and beyond the expected from the underlying pathology. And infantile spasm syndrome may be one of those, especially those of unknown etiology, or developmental epileptic encephalopathy with continuous spike and wave discharges. A next committee that Ingrid Schaeffer and Annie and several of us were involved put together this concept that you may have a developmental and or epileptic encephalopathy. So you can have the epileptic encephalopathy by itself. You can have a developmental disorder that you can have occasional seizures, but the seizures do not make the person, they do not aggravate the underlying disease. And you can have those that they have a developmental abnormality and an epileptic encephalopathy at the same time. So in many encephalopathies, there is a developmental component that's not dependent on the epileptic component. The developmental delay precedes the seizure onset, and the seizures do not make the situation worse. And an epileptic encephalopathy will be those that they see, even though the seizures stop, you can have the developmental and epileptic encephalopathy. Even if the seizures stop, the patient does not get better. So now I'm going to go through quickly showing you what is published in the papers, and you will see a recurrent motif. We classify the syndromes in 4 categories: neonatal, infantile, child, and occurring at every age, as well as those with generalized onset. And if you can see, we have those that are self-limited, meaning that the seizures will stop. Those that they have a developmental and epileptic component. And the neonatal period is the early infantile DEE, which is a combination of the early myoclonic epilepsy and Ohtahara syndrome. Then we have etiology-specific epilepsies that we need to identify more and more as we move forward. The same is applicable for infantile seizures, again, self-limited epilepsies, developmental and epileptic encephalopathies, etiology-specific. The same for the child. And here we also can include some of the generalized epilepsies. There is also patients that they can have the onset of the seizure at any time of their lives. They can be generalized syndromes. They can be focal epilepsies. They can be combined focal and generalized epilepsies. They can be DEEs, and as well as etiology-specific syndromes. And then we have the idiopathic generalized epilepsy syndromes, and at this point there are 5 categories that we have included. I will not go to specifics of all of them. There is some controversy about the epilepsies with generalized tonic-clonic seizures alone, because it was thought that most of the seizures will occur upon awakening, but Occasionally, they can occur on other times of the day. So the committee suggested that we use the term, to avoid to use the term while upon wakefulness. Another way to look at this is how the focal syndromes change as a function of age, and some of them appear early on, some of them appear much later on. And please pay attention to sleep-related hypermotor or hyperkinetic epilepsy, those that they present with very peculiar movements that we used to think that the patients were crazy, then occur even in children as well as, although the majority is after the age of 8 years and further up. And again, the way the graphs are designed is to show the time that the more prominent the symptoms are. The same is for the generalized epilepsy syndromes, and you can see that, I'm sorry, that phone is gonna ring and I have to get up to change it, so ignore it. The generalized epilepsy syndromes that may have different kinds of onsets, and we described all these syndromes in the papers that were published a year ago in Epilepsia. And these are the syndromes that are related to progressive encephalopathies. And again, you are fully aware of most of them. You need to be aware how we're going to treat them effectively, and we need new treatments. So the neonatal and infantile syndromes, they are the self-limited epilepsies. We have the self-limited familial neonatal epilepsies, those that they are neonatal and infantile. Some of them are very responsive to sodium channel blockers that you need to think very quickly if they fail the first medication, which is usually phenobarbital, although in some other centers in this age group, they give levetiracetam without any, although the studies do not show that levetiracetam is better than phenobarbital. But if phenobarbital, if the seizures happen during the second or third day of life and the seizures have not stopped, using a sodium channel blocker is warranted because there is a miraculous response. The way the first study was done, they used carbamazepine because phenytoin is not available in Europe, but you can also use phenytoin to acutely stop the seizures. But after that, you need to make sure that you have adequate phenytoin levels. And then you have the self-limited infantile epilepsies that they may be associated with genetic variants. And in each chapter, in each paper, they says what are the characteristic features, what are maybe points of concerns, and what are items that may totally rule out the possibility of being that syndrome. And you can see the other specific, the etiology-specific syndromes, as well as the developmental and epileptic encephalopathy. I like to make a joke that GLUT1, glucose transporter 1 deficiency syndrome, is something that I look often because it's very, very treatable. And at Columbia, which is about 10 miles from Einstein, they have a lot of cases. At Einstein, Montefiore, over the last 20 years, we had one. I'm still looking. The spectrum of syndromes in childhood, again, follows the same kind of category. And you have those that do not have a developmental encephalopathy. They include the initials that you will you need to learn them. SELEX is self-limited epilepsy with centrotemporal spikes. SELES is self-limited epilepsy with autonomic seizures. Before that, it was called Panayotopoulos syndrome. I don't know what's easier for you to say Panayotopoulos or SELES. But what we decided as a group is that we will take away the names of people except for 3. And those 3 are Lennox-Gastaut, because there is a foundation of patients that helps with research and they cannot change the name. So they ask us to keep the names Lennox-Gastaut. Dravet syndrome, again, there is a foundation that very much raises money and helps in research for Dravet syndrome. So we kept that name. And finally, for Rasmussen, because there is no better way of identifying it as a syndrome yet, but eventually it may happen. COVE is childhood occipital epilepsy, occipital visual epilepsy, which used to be called the Gastaut type of occipital epilepsy, but now we call the name COVE. And then you have those that they may be associated with an epileptic encephalopathy, or if there is an injury before, developmental and epileptic encephalopathy with activation during sleep. Again, I described what the self-limited syndromes are in the previous slide. And important to know is that remission of the seizures occurs at about adolescence. We do not know exactly. It used to be thought that it stops at the age of 15, which I thought it was related to when pediatric epileptologists gave the patients to the adult epileptologist. And at that time, also, adolescence was around age 15, but we need better studies to understand what causes for the remission of the seizures. The generalized epilepsies can, again, identified as those called idiopathic generalized epilepsies. All of them are genetic, but they are, or we think they are genetic, but in certain parts of the world, calling someone as having generalized epilepsy induces a stigma and makes it very difficult for anyone to difficult to get married or have a life. So we keep the term idiopathic generalized epilepsies. There are 4 categories, of which the generalized tonic seizures alone is the smaller group because they are more rare. And then you have those that are associated with epileptic encephalopathy. This one, epilepsy with myoclonic atonic seizures, used to be called Dozy syndrome, now has a new name. And then you have the epilepsy with high lead myoclonia, that used to be called Gibbon syndrome by some people. Again, the same has changed. And the way it's shown is those that are on top are more likely to have an epileptic encephalopathy. So if you control the seizures, you may have a better outcome. But in the bottom, even if you control the seizures, the outcome may be not as good. And this is the developmental component that's already there. I presume by now you see the recurrent theme of what we do. These are the epilepsy syndromes, again, a childhood absence, epilepsy with high lead myoclonia, with the different characteristics. And each paper has the specifics that you need to take into account. The syndromes that occur in variable ages are described in the paper by Rani, which is a tour de force because covers almost all age groups. And again, you have the self-limited categories, those that are associated with developmental and epileptic encephalopathy. But since they can occur in any age, we cannot say that you have a developmental encephalopathy at the age of 18 or 15. So we came up with the term that you have a progressive neurological deterioration, which is applicable to all these people who are not expected to continue developing with age. So by the time you reach adolescence, I think we have to stop using the term developmental. It's already done, it's static from there on, or whatever you have, if you lose your ability to perform, you have a progressive neurological deterioration. And there are syndromes that can have both the focal epilepsies, but they can have some worsening and developmental and or progressive neurological deterioration, including MTLE with HS, the sleep-related hypermotor or hyperkinetic epilepsy, and the familial focal epilepsy with variable foci. The majority of them do not, but you need to be aware. And also here, for the first time, you start looking at the progressive myoclonic and myoclonic epilepsies. The generalized epilepsy syndromes are those I described in the previous slides, and you have those that they have combined generalized and focal epilepsy syndromes, and this is epilepsy with reading-induced seizures, which beg to discuss what a reflex seizure is. Very recently, there is an attempt to try to show you visually how this is going to look, all these categories that are put together. And Doug Nordley, father and son, just published a paper that are trying to see it as a matter of a pie. So above the line is you have a normal interictal EEG, excluding ERDA or FERDA. That's not part of it. And on the bottom, you have an abnormal EEG. And on the left side, the abnormalities would be diffused, and on the right side, it will be focal. And if you put there, you can put all the syndromes, and you can see how applicable they're going to be. I think it's a neat way of looking, but you need this table as well to tell you which syndrome it is, because you're not going to remember all of them. Now, we also need to figure out what is a reflex epilepsy, and that's also discussed very nicely by Riney in that paper. And a reflex seizure is a seizure that is consistently or nearly consistently elicited by specific stimulus, which can be elementary or it can be complex. And it does it all the time. We could not be sure that the reflex seizures are epilepsy syndrome, so we did not include them in the syndromatology, but more work needs to be done. Febrile infection-related syndrome is a syndrome that one has to be fully aware because it has almost tremendous implications in the outcome. We do not know how to treat it very well. And the advantage of me showing you this is that you can see what the mandatory features are, alerts that make you think that there may be something that's suspicious that may not fit in the category of a febrile infection-related syndrome. And exclusionary is something that tells you that if this happens, is not part of the syndrome. And for every syndrome that's described in those papers, tables such as this one are there. Fires is a condition that we see in kids, but we also have new onset refractory status epilepticus. And this is syndromes that we need to address on how to identify the etiology, because the prognosis is still dismal. So in summary, I went through with the classification, what's a seizure, what it is, the classification of seizures, the epilepsies. I separated neonates or patients with changes in the mental status that cannot describe their symptoms, and we need to have a different categorization of their seizures, and we need the EEG for that. And then I also describe the etiology, the epilepsies that we may have. And the bottom line is we need to have etiology, and comorbidities. Treating the seizures alone is not good enough. We need to go to the to treat the patient in total. So not every paroxysmal event is an epileptic seizure. Seizure onsets count for classification of seizures in awake patients. The EEG is crucial for classification of seizures in patients with altered mental status, and the classification takes into account the predominant seizure type. You need to define epilepsy and its syndromes. Beware of the comorbidities, and again, etiology. Thank you. This is a young person with epilepsy, and this is Spiros Papadimas, a very famous Greek weightlifter who was part of a book that we put together to stand up for epilepsy, to recognize that people with epilepsy are people, and we need to help them in every way we can. Hopefully, our definitions will allow us to create and explain the situation much better as we go along. And one of the major problems that we face in epilepsy is that we do not have enough money to do research to understand why people develop epilepsy and why are the people who are going to do very badly. But epilepsy is a disease that covers the whole spectrum. It's epilepsies, and you can have benign conditions, self-limited conditions, and developmental encephalopathies. But the argument we have to authorities is that every epilepsy is bad for you. Epilepsy kills, because otherwise we will not get the attention of the authorities. And that's a very important message that we need to start, at least to identify what makes the non-self-limited epilepsies exist and how we can take care of them. Thank you.